What's up, Ninja Nerds? In this video today, we're going to be talking about drugs for epilepsy. Before we get started, really, I urge you guys, please, if you guys do find these videos helpful and they make sense, please support us. And I mean this. The best way that you really can do that is by hitting that like button, commenting down in the comment section, and please subscribe. It just really helps us to continue to keep making free videos for you guys' all enjoyment and academic advancement. So please check that out, please. Also, if you guys really have a strong interest in really understanding this topic, I highly suggest you go down in the description box below. There's a link to our website. On that, we have some amazing notes, illustrations that our Ninja Nerd team has kind of whipped up for you guys that I really think will help you guys in understanding this topic as we go along. Print off those templates, print off those illustrative diagrams, and follow along with me. Fill in the blanks. I really think it's going to help you guys, because then you get a little bit of that my voice in there, you get a little bit of drawing in there, you get a lot of visual stimulus. I think it's all those learning pathways. So please do that. Without further ado, let's talk about the drugs for epilepsy. Now, in order for us to do that, in order to talk about all these different drugs, their mechanism, what are they actually used for? Like, how do I know which one's best for which type of epilepsy? And then what are the adverse effects? All those things that we're going to discuss, we have to get ourselves kind of built on that foundation of what is epilepsy, right? And so there's a slight difference between seizures and epilepsy. So seizures are generally, it's the event of where a patient may be having or exhibiting this high electrical discharge from the central nervous system. But if it's kind of a one-time event, a one and done kind of thing, that's kind of what we classify as a seizure. But if they're having multiple seizures, like, okay, so usually 2 or more seizures that they haven't resolved, that it's continuing to happen chronically, then we see a disease of epilepsy. So that leads to the question, right? So epilepsy is when a patient is having continuous recurrent seizures. So there's different ways that a patient can seize. In other words, you could have 3 types. What I really want you to remember is focal, generalized, and then we call this third one, it's like an unknown, but we kind of fit this in kind of this random category called epileptic spasms. If you had picked 2 that I really want you to remember, it's focal and generalized. Please don't forget that. So when we talk about focal seizures, really, there's this particular area in the actual brain, in the central nervous system, that's becoming agitated. Like maybe it's here near the cortex. And in this region here, there's this agitated focus here, where the neurons in this part of the cortex are agitated and it's sending these high electrical discharges. And depending upon where it is in that part of the cortex depends upon what type of seizure they actually present with. Just as a quick example, if a patient had, for example, irritable area in the right motor cortex, what do you think would happen? They might start exhibiting only left-sided type of symptoms. So left-sided kind of movements, abnormal movements. And that's really important. So that's a focal seizure. Now, focal seizures are really interesting because they can happen where you actually have no loss of consciousness or you have loss of consciousness. And that determines if it's a focal seizure with impairment or a focal seizure without impairment. But on top of that, the other concept behind this is that it could be motor, it could be sensory. So if you hit the sensory cortex, there's an irritable area there, you may have abnormal sensation or loss of sensation on that left side. So you get the point. You can have different types of focal seizures. The next one's a generalized seizure. In this sense, there is multiple areas of the cortex that are agitated, irritated. And these are sending these irritable types of signals all over. Look at this. This is terrible. Multiple areas of the cortex are agitated, irritated, and they're sending all of these high electrical discharges all over. These patients usually have impairment or loss of consciousness. They don't really remember the event that well. Okay, so that's a really important thing, is that generalized seizures, they oftentimes present with a loss of consciousness or a degree of impairment where they forget everything that happened. Now, with generalized seizures, there's different types. Really quickly, one of them that I want you guys to remember here, that's that common, that scary one that you see, is that grand mal, that tonic-clonic seizure. That's one type. The next one is where the patient has a really massively increased tone and their muscles are just literally like locked up. That's called a tonic seizure. Then you can have clonic seizures. So you kind of have tonic-clonic as a mixed, right? So clonic is like this. So but you have tonic-clonic where now you have increased tone and you have that clonic movement. So you can have clonic, you can also have where the muscles literally go limp. Not even kidding, and they can completely go limp, and this is called atonic. And then you have another one called myoclonic. And this is usually quick, jerky movements. Quick, jerky, rhythmic, rapid types of movements, all right? There's one more which is also considered to be a part of the generalized seizures, and this is a really interesting one, so I want to add this one over here that you guys don't forget. So this would be the 6th type, and this is called an absence seizure. Absence seizures are really kind of sad. They happen in young pediatric patients, and usually this is classic for them to kind of be in class, young pediatric patient, staring out, zoning out, forgetting everything that usually happened during that time period. We also call them like petit mal seizures, so really important one there. The last one, just really quickly, I don't want us to go too crazy here. We don't really know the actual true mechanism of kind of how this is all happening, but there is 3 particular ones that I want you to know. One is called benign Rolandic spasms, so benign Rolandic. The second one is really an important one called West syndrome. So I really want you to remember this one here, West syndrome. And the third one is a sad case. I've seen 2 cases of this in my neurology team, patient population, but it's called Lennox-Gastaut syndrome. And it's a really sad condition where they have multiple seizures every single day, and it's almost impossible to be able to control. But these are the different types of classification of epilepsy. And it's important to remember that epilepsy is continued recurrent seizures that happen again and again and again. When a patient has seizures, we know now that there's focal, generalized, and epileptic spasms, with the emphasis on these 2. Why did I introduce this? Because guess what? Different drugs treat different types of seizures. So I have a specific drugs that'll treat focal seizures. I have specific drugs that'll treat tonic-clonic, absence, myoclonic seizures. So it's really important to remember. With an emphasis that I really want you guys to focus on this one, myoclonic, absent, and tonic-clonic. Just being that these are likely going to be the most common types of seizures that you will see, as well as focal seizures. And then, unfortunately, West syndrome is the big one that I want you to remember as well. All right, that leads to the next question. All right, we have these irritable areas of the brain tissue that's causing this abnormal discharge of electrical events. It's causing these patients to develop many different things. Focal seizures could be one limb. Generalized could be bilateral, but they lose consciousness, and it could be tonic-clonic, tonic, clonic, atonic, myoclonic, or they just blank out, absence. What's the reason that this area of the cortex becomes so irritable and starts sending off these discharge, whether it be focal or generalized? What is the trigger? That's the question, right? What is the thing that's activating or triggering this particular focus now? That's what I want you guys to be thinking about. And I want you to remember the mnemonic vitamins, or actually, I'm sorry, vitamin D, E, okay? So V is for vascular etiologies. And so if there is some type of bleed within the brain, that can cause an irritable area of the brain. Just a quick example, if someone has a bleed, if someone has a subarachnoid hemorrhage, if someone has an acute ischemic stroke, those are particular areas where you damage that tissue, now it can become irritable. I is infectious. So if someone has things like meningitis or encephalitis, I'm just gonna put meningitis or encephalitis, this could be a potential irritable kind of focuser because the meninges are right next to the cortex. T, trauma. So sometimes if someone bangs their head and they get a bleed that's kind of compressing an irritable kind of focus to the brain tissue here, such as an epidural hematoma, a subdural hematoma, these are other ones. Autoimmune. So this could be a patient who has an underlying autoimmune disease. Examples could be something like SLE, and they trigger antibodies, and these antibodies go and attack parts of the brain tissue and cause irritability and inflammation of the brain tissue. Sometimes it can even be something called paraneoplastic, where you have a cancer, and then that cancer produces antibodies. So if you really wanted to remember that, you could add a second one called paraneoplastic. All that means is, to give you an example, I have a tumor here. Here's my tumor cell. It produces antibodies, and these antibodies go and attack the actual cortex of the tissue. All right, so that's the part for vitamin, right? So we're almost there. M is metabolic. And this, believe it or not, tends to be pretty common. There's many different things. One that I really want you to remember is hyponatremia. Believe it or not, high or low glucose can do this. And things like thyroid disorders, lipid disorders, those are also big ones as well. Another I is idiopathic, meaning we don't really know why this happens. This tends to be these epileptic types of disorders that I want you to remember. The next one is neoplasia, and this is obviously really sad, but someone has some type of mass, right? They have some type of primary mass like a GBM. They have a metastatic lesion that spread from somewhere else. Sad, sad cases there. And then the other one, which, believe it or not, is very, very common, drugs and toxins. And this list could be never ending and so long we can't go through all of them. But remember that. And then the last one is that pregnant patient, the eclamptic patient. So eclampsia would be another particular one to remember as well. All right, so the basic concept is we have things that can trigger patients to have seizures. The vitamin D and E would be the things that can trigger this area to become irritable, cause that cortex to start sending off these high electrical discharges, which if it causes only one arm or to have motor movement or sensory loss, then it could be a focal seizure. If it's complete loss of consciousness, bilateral generalized, tonic-clonic seizures, that could be one type of presentation. They could also be completely tensed up, tonic. They could have some type of movement like this, clonic. They could go limp, atonic. They could have rhythmic, discharging kind of rhythmic movements, myoclonic. Or they could have absence where they lose consciousness and then completely blank out and stare. The next question that you have to ask is, okay, I know the thing that triggers this. I know if this thing becomes irritable, what it can present like. If we get down to the neuronal level, what's actually happening there? Let's talk about that. So what I wanted to do is I want to kind of zoom in on this irritable area. The irritable area in the brain where there's this trigger of kind of seizures. It could be one area, it could be the entire cerebral cortex, right? And that's kind of the basic concept between generalized and focal seizures. Now, it is important to remember that a patient can have a focal seizure that's secondarily generalized. In other words, you could have this focus here where a patient has electrical discharges, and then at some point they lose consciousness and have bilateral kind of all extremity involvement. So you can have a patient who has focal seizures that progresses into a generalized tonic-clonic seizure. So that's important to remember. But nonetheless, if we zoomed in on these areas of irritability within the cortex and we looked at this neuronal type of diagram, this is really where it's important. So let's say here's the neuron. Here's the neuron that's the problem, and it's sending these action potentials down the axons that are triggering this seizure activity, if you will, right? This is the neuron that's giving us some problems. There's other neurons that influence this particular neuron. Okay, this is our seizure neuron. What I really want you to remember is the basic kind of mechanism behind this is that you have too much glutamate activity. That's one particular reason, is high glutamate activity that can cause seizures. I'll explain why that is in a second. The second one is there's very little GABA activity. So there's very low or decreased GABA activity. And it's these two particular things that are the primary kind of reason why patients develop these seizures. Let me explain. Here's a neuron, and this is a glutaminergic neuron. In other words, it releases out of these axons here, out of this neuron, it releases the chemical called glutamate. So all of these little circles here are called glutamate. Now, the way that this neuron releases glutamate is important because it's going to come into the drugs later. Here we have an axon here, right? Here's the axon of the neuron. On the axon, there's these special channels called voltage-gated sodium channels. I'm just going to mark this as point 1. So point 1 is the voltage-gated sodium channels. When these become active, sodium will rush into the cell and make the axon positive, right? So it'll engage in what's called depolarization. That depolarization is the thing that triggers the second step. So we have sodium rushing in that triggers the depolarization of the axon. That depolarization of the axon then stimulates these next channels. The second channel. The second one is these green channels called the voltage-gated calcium channels. Whenever sodium rushes into the axon, it depolarizes the axon, then it opens up these voltage-gated calcium channels, and calcium will flood in. When calcium floods in, the reason why it's so special is it binds on to these different types of vesicles, these proteins on these vesicles, which helps the vesicle to fuse with the cell membrane and release out the glutamate. So there's another important part, which is you need these particular types of proteins or receptors to bind calcium or to fuse with the cell membrane. That's a third point. The next thing is that the glutamate, that's when it's released into the synaptic cleft, has to go here and bind on to these little pockets here called these different types of receptors. These are special receptors here where it binds onto and triggers these channels to open. When they open, they lead to things like sodium and calcium rushing in to the actual cell. When it rushes into the cell, these things do what? They increase the action potential type of pathway. So then you get an increase in the action potential pathway, which causes an increase in seizures. Why? Because they depolarize this neuron. They make it super positive. So they're going to make this neuron super positive and cause it to depolarize. So if you have excessive glutamate release, this is going to cause an increase in the action potentials from this irritable focus area. Okay, let's come to the other part. Here's a GABAergic neuron, meaning that when this neuron releases particular chemicals from this actual neuron, it releases all these like blue dots here. You know what these blue dots are called? Shocker, right? It's called GABA, gamma-aminobutyric acid. Now, this gamma-aminobutyric acid is very special in the sense that in order for this one to get released, there usually is an action potential that comes down the axon, right? So there is some type of action potential that comes down these axon, but there's no special channels that are relevant to the pharmacology. What it'll do is it'll lead to the stimulation of these vesicles to fuse with the membrane and release GABA. GABA will then go and bind on to this particular types of protein here. And this is called a GABA-A receptor. I really want you to know this as, again, the fifth point here, because this is a very specific point. If we can have, again, GABA bind onto this receptor, it should do what? Normally, it should allow for chloride ions to come into the cell. If chloride ions come into the cell, what would be the effect then? The effect is that if you have chloride ions, it'll make the cell super negative. And that will do what? That'll try to inhibit the increase in action potentials, right? So it's going to try to hyperpolarize the cell. But the problem is that there's some type of dysfunction at the GABA-A receptor where this doesn't work. If this doesn't work, you get less chloride influx and you get less inhibition of this actual hyperpolarization. You don't hyperpolarize as much, so therefore you end up causing stimulation of an increase in action potential. So again, I want you to remember, normally GABA will cause chloride ions to influx, hyperpolarize the cell, and inhibit action potentials. But in this disease, you're not making a lot of GABA or producing enough GABA, or the receptors aren't responding to the GABA. So therefore, chloride ions don't flow in, they don't inhibit action potentials, and instead they lead to the stimulation of action potentials. Oh, that's not fun. Okay, well the next thing is the GABA, once it's actually released, it has to get recycled. And when it gets recycled, it's important to know that in this particular thing, if there was a particular way which GABA, maybe there's a lot of uptake, now there's less GABA present here in the actual synapse. So sometimes this is another thing where there's an increase in GABA reuptake. And there's less of this GABA available to bind onto the receptors, cause chloride ions to flow in, inhibit action potentials. But if you're taking a lot of it in, there's less GABA, less ability to get chloride in, less ability to inhibit the action potentials, and seizures occur. There's another step. And there's another one more in here, which is, I'm going to get rid of this part here. I'm going to get rid of this part here. When GABA comes in, back in to the actual neuron, it can get recycled or it can get metabolized, and it can be turned into an inactive metabolite. And so if there was a potential process here on this seventh step here where there was an increase an increase in the breakdown of GABA. There'll be less GABA that can be recycled, less GABA released, less GABA to bind onto the channels, less chloride coming in, less hyperpolarization. Therefore, you're going to depolarize and stimulate action potentials and cause seizures. That's the process that I really want you guys to remember here. And the reason why is I'm going to give drugs to block the sodium channels. That'll block glutamate release. I'm going to give drugs that block calcium channels. That'll block glutamate release. I'm going to give drugs that block these proteins from fusing with the cell membrane. Therefore, these vesicles won't fuse and release glutamate. I'm going to give drugs that block these receptors that allow glutamate to bind to them and cause ions to flow in and trigger action potentials. I'm going to give drugs that stimulate the GABA A receptor, increase chloride ion influx. If I do that, I'll cause the cell to hyperpolarize and inhibit action potentials. I'm going to give drugs that inhibit the reuptake of GABA so that more GABA stays in the synapse, binds to these receptors, causes chloride ion influx, hyperpolarize, and inhibits action potentials. I'm going to give drugs that prevent the breakdown of GABA so that more GABA is getting recycled, being released, binding on, inhibiting action potentials. And that is the next step that we have to talk about, which is the mechanism of action and the names of all these different drugs. All right, my friends, so now we've kind of got to the point that we know that one of the pathophysiological points or the mechanisms behind epilepsy is that there is, again, an increase in action potentials. And these increases in action potentials are leading to an increase in these seizures that we see, whether it be focal or generalized, right? But we said that the basic reasoning behind one of them was that there was an excessive increase in the glutamate activity. So now what I want to do is I want to come up with a mechanism, right? So the increase in glutamate activity was really causing this problem. It was leading to increased action potentials and then subsequently increase seizures. So my goal is I want to come up with drugs that are going to inhibit that glutamate activity. And so my end goal is to decrease the action potentials within this neuron and therefore decrease the electrical discharges leading to decreased seizures. So how do I do that? Great question. First thing is I want to block the sodium influx. If I can block sodium influx, I prevent sodium from coming in. So I'm going to inhibit sodium influx. Then I won't lead to depolarization. I won't depolarize. I'll inhibit the depolarization. If I inhibit the depolarization, then I won't stimulate these particular channels called calcium channels. I won't allow calcium to flow in. I won't allow the calcium to bind with the vesicles, to fuse with the synaptic membrane, and to release what chemical out here? Glutamate. I won't allow glutamate to bind onto these receptors, causing sodium influx, calcium influx, which both collectively depolarize and lead to a decrease in action potentials and a decrease in seizures. So if I block the sodium channel, I block all the downward cascade effect. So that's where these drugs come into play because they're going to do, again, what? They're going to work on inhibiting these particular channels. So that deserves the question, what are these drugs? So first one that I want you to remember here is carbamazepine. Carbamazepine is a really great drug. Carbamazepine. Another one is a close friend or cousin of it, which is called oxcarbazepine. Another good drug that you can actually put in this category is called phenytoin. And then its cousin, fosphenytoin. Another one is called lamotrigine. Another one is called topiramate. And then the last one that I want to put in this list is what's called valproate. There is another one called lacosamide. You can also add that one in there. I'll just do it for you guys. There's another one called lacosamide as well. So these drugs all have the ability to inhibit this particular channel, prevent glutamate release downstream, which leads to decreased stimulation of these neurons, decreased action potentials, and decreased seizures. Cool, that's it. This is the most challenging group to remember because there's so many dang drugs in it. Go through it a couple times, write it out a couple times, and just keep trying to go through it. I wish I had a trick, a mnemonic to help you guys remember it. I don't, I apologize, but just keep trying to go through these a couple times. All right, next one is the calcium channel blockers. The calcium channel blockers, again, they're going to inhibit this calcium influx. If you inhibit the calcium influx, calcium won't be able to come in. If calcium can't come in, it can't stimulate the fusion of these vesicles with the membrane. It can't release glutamate. It can't stimulate these actual neurons to cause sodium-calcium influx. It doesn't allow action potentials, and it decreases seizures. It's pretty straightforward, right? So calcium channel blockers, the big one that I want you to remember is called ethosuximide. Now, back in the day, we used to use another drug category. I'm not going to put them in here because we don't utilize them for seizures as much anymore, but we used to use drugs that would bind to an alpha subunit on the calcium channel and inhibit that, which would allow the calcium to go into the actual neuron. And this used to be for gabapentin and pregabalin, but we don't utilize those as much anymore for seizure or epilepsy. Again, it's more for like your neuropathy types of pain and situations like that. So ethosuximide, actually this is an I, ethosuximide is going to be the primary one that I really want you to remember here, okay? The next one is what if I block the third point, which is I block or I inhibit the fusion, right? I inhibit these particular cute little proteins, these little SV2A proteins, synaptic vesicle proteins that are supposed to fuse with the cell membrane. When they get bound by calcium, they're supposed to fuse with the cell membrane and then release glutamate. If I inhibit it, they don't fuse, they don't release glutamate, doesn't bind onto these channels, doesn't allow sodium-calcium influx, doesn't cause depolarization, doesn't cause action potentials, doesn't lead, and then inhibits seizure production. This drug is going to be a heck of a one here called levetiracetam. Levetiracetam. This is actually a really, really great drug. Very, very little adverse effects, and it's just very, very effective. All right, next thing. So we blocked sodium influx, which led to inhibit depolarization, calcium influx, and all the downstream effects. Calcium channel blockers, ethosuximide. Blocking the vesicles, SV2A receptor blockers. Then we can block the glutamate from binding onto this receptor or this receptor. This one here is called an AMPA blocker. So we're going to inhibit this particular channel here, preventing glutamate from binding into it and causing sodium influx. The primary drug in this one is called felbamate. It's called felbamate. Then we have another one which is going to inhibit this particular one, and that's the NMDA receptor blocker. And this primary one that I want you to remember is going to be ketamine. All right? So from this, what I really want you guys to understand is there's drugs that'll help to be able to block the seizures or inhibit seizure production by doing what? Decreasing the glutamate activity. Their whole job is to do what? All of these drugs, these AEDs, all of these AEDs will do what? They will work to inhibit the increase in glutamate activity. And that includes sodium channel blockers, calcium channel blockers, SV2A receptor blockers, as well as AMPA receptor blockers and NMDA receptor blockers. Beautiful. Well, then that leads to the other mechanism, which is the patient who had very little or decreased GABA activity. What if we had AEDs that could increase GABA activity? Let's talk about those. So again, we said that whenever patients are having seizures, right, there's generally these neurons here, the problem, they're having an increase in action potentials. And one of the reasons why was that there is a decrease in what? There was a decrease in the GABA activity. So GABA wasn't binding onto these receptors well, as you weren't having enough GABA, you weren't releasing enough GABA, GABA wasn't binding to the receptors appropriately, whatever it is. And the result of that is that decrease in GABA activity led to less hyperpolarization. And so that increased the action potentials and then subsequently increased the seizures. Well, now what I gotta do is I gotta come up with some AEDs here, some different types of anti-epileptic drugs that'll help to inhibit this decrease in GABA activity. In other words, we want to increase GABA activity. How do I do that? Great question. Well, the first thing is GABA is going to fuse, right? So there was no specific kind of sodium, calcium channel type of blocking activity. There was no specific type of synaptic vesicle proteins that were relevant that we discussed in the mechanism here. It's just we know that GABA is released from these GABAergic neurons. When GABA is released, what it does is it binds on to this particular protein here, this receptor. And this is called a GABA-A receptor. When it binds onto this GABA-A receptor, what it does is it causes chloride ions to influx into the cell. That's naturally what should happen. When chloride ions influx into the cell, it makes the cell negative. And what that means is it causes the cell to hyperpolarize. And if it hyperpolarizes, it decreases the action potentials, and that will decrease effectively that seizure production. So that begs the question, is there some way, somehow, I can have drugs that could bind onto this GABA-A receptor, stimulate this son of a gun, or increase the activity in its response to GABA? Abso-stinking-lutely. And that's called GABA-A receptor agonists. They're going to bind to the GABA-A receptor and increase the activity of that receptor, acting as if GABA was already binding. What are those drugs? So if we stimulate this, more chloride will flow in, more hyperpolarization, decreased action potentials, decreased seizures. These drug categories, the first one that I want you to remember is called benzodiazepines. And there's so many in this particular category. I'm only going to list the relevant ones. So the relevant ones include lorazepam. This is a big one. Midazolam is another big one. Diazepam is another big one. And there is a few other ones, such as clobazam, which is a newer type of benzodiazepine, and clonazepam as well. But these are one great drug where they have the ability to bind onto these GABA-A receptors and increase, this is keyword here, I can't stress this enough, they increase the frequency of the opening of the chloride channels. In other words, when benzodiazepines bind onto these GABA-A receptors, they increase the frequency at which those channels open and allow for chloride ions to flow in. There's another drug that also does this, and this is called barbiturates. Barbiturates. Now, barbiturates include drugs like phenobarbital and another one called pentobarbital. And these drugs are really, really powerful, extremely powerful. And what they do is they bind onto the GABA-A receptor, cause it to open up, but keep it open very long. So they increase the duration. They increase the duration of the chloride channel opening. You know how someone told me to remember this? Ben, the husband, would like to have things with his wife more frequently, all right? Whereas Barb, the wife, would like Ben to be able to do things a little bit longer in duration. So that's how I was helpful to remember this in one of my classes in pharmacology. And I think that this has stuck with me since. I hope that helps you. So these are the big drugs that have this ability. There's another one that I really want you to remember here is propofol. So propofol is a very powerful type of medication that also has this ability. Another one that you can also add into the mix here is called topiramate. Wait, you're like, wait, topiramate. Didn't I see that drug up there before? Absolutely you did. So just remember that topiramate, I'm going to represent this kind of in a two different color here, has an ability to decrease glutamate activity, and it has the ability to increase GABA activity, which is pretty cool. All right, so topiramate has kind of a dual action. And a lot of these drugs do have dual actions. I'm just going to mention a few that are actually pertinent. All right, so there's one way that we can do this. One way that we can increase GABA activity is by giving drugs that bind onto the GABA-A receptor to open it up, cause chloride ions to influx in there, and cause hyperpolarization, decrease action potentials. These are the drugs here that I want you to remember, with the emphasis on benzodiazepines and barbiturates, and then the emphasis on which one increases frequency and which one increases the duration. Ben likes it more frequent, Barb likes it longer. All right, next thing. We also said that another problem is that when GABA is done performing its action, it gets taken back up into the actual axon. And then two things can happen. One is once the GABA is inside, it can get metabolized into an inactive metabolite, right? Or it could get recycled back up into this actual vesicle, but some of it could get broken down. What I would like is maybe if I keep as much GABA out into this actual space, it can bind onto more of the GABA A receptors, cause more chloride influx, and then cause a decrease in action potentials. So I'm going to give a drug here that inhibits this channel. So then GABA won't get taken back in. If GABA doesn't get taken back in, then the GABA will be in higher levels in this actual synapse. And it'll have more powerful stimulation of these receptors, more powerful chloride ion influx, more hyperpolarization, decreased action potentials, and decreased seizures. What is the drug that actually does this? To be honest with you, it's not really utilized that much unless it's very refractory partial seizures, and that's the only time that we're going to mention it. This is called tiagabine. And I'm just going to mention this here. It's not frequently utilized. It's primarily utilized in focal seizures. So it's primarily utilized in focal seizures that are generally pretty refractory to a lot of your first line therapy, which we'll talk about. All right. All right, the last thing is we either binded the GABA A and increased its activity, we inhibited the GABA reuptake protein so that we keep more of it in the synapse to bind to the GABA A receptors, or we prevent the breakdown. So in other words, what if we did this? What if we said, okay, GABA gets brought back in, yes, it's gonna get brought back in. How about I make sure most of it, almost all of it, gets recycled back into this vesicle. And I basically don't allow this process to occur here. I'm going to inhibit this enzyme so that I don't make any of this inactive metabolite, and most of it goes into this actual vesicle so that I can increase the amount of GABA that's getting released with every neurostimulus. That sounds pretty interesting. And the drugs that actually do this that I want you to remember are called vigabatrin, and then the other one is called valproate. And you're like, wait a second. Valproate, that sounds familiar. It sure does, my friends. Valproate was a sodium channel blocker like topiramate, which means that like topiramate, valproate has the ability to do what? Decrease the glutamate activity by inhibiting the sodium channels like topiramate, and it also has the ability to increase the GABA activity by inhibiting the breakdown of GABA into the inactive metabolites, whereas topiramate bind onto the GABA A receptors and act as an agonist. Beautiful process of all of these drugs. So that's what I want you guys to remember when you go through here. Okay, which is the drugs that basically increase GABA activity and which are the drugs that decrease glutamate activity. That's the process. Now, we gotta go on to the next step, which is we have a patient who has focal seizures, generalized seizures, right? We found the underlying cause. We treated the underlying cause, but they continue to have seizures. Now they have epilepsy. We have to then say, okay, which drugs could I give that'll stop this focal or generalized seizure, which is going to be treated by decreasing their glutamate activity or increasing their GABA activity. So let's find which drugs are best suited for that specific type of seizure. And we're going to focus on first-line medications. Let's talk about it. All right, my friends, so let's now talk about how we're going to approach treating epilepsy, particularly utilizing anti-epileptic drugs. So one of the first things is, okay, we obviously can give medications to patients who have epilepsy, but you have to treat the underlying cause. So if the patient has a particular cause that can be reversed, and then they don't require an anti-epileptic, that's great. So again, you have to be able to remember that. So just a quick caveat here is just remember, always treat the cause. The reason why is they may not require, they may not need an anti-epileptic drug. All right? But if you found it, you've gone through, you've tried to treat the cause, they continue to have seizures, or they have no identifiable cause that you've been able to elucidate, then you're probably going to need AEDs to continue to suppress or prevent their seizure activity. So that's the first thing. So I have epilepsy, right? I've tried to treat the cause, or I've tried to find a cause and see if they don't need it, but if they do need it, I need to find which AED I can pick for the patient that is going to be the best suited, it's best found through evidence to treat that particular type of seizure disorder and doesn't have any significant adverse drug reactions. If I've gone through that and the patient is seizure free, okay, then I'm done. I don't have to do anything else. That's great. But if the seizures continue to persist, so the patient continues to have seizures, then I gotta go and I gotta think, okay, well maybe this wasn't the best AED. So then I gotta look at doing a second AED, and then I gotta start decreasing the first AED. So start titrating the first AED. So that's the whole point within this one. So a patient has epilepsy, you have to find the underlying cause, treat that. If you treat it, they get better, they don't have seizures, then you don't maybe need to put them on an AED. If they have no identifiable cause, or you've treated the cause and they continue to have seizures, put them on the first line AED that fits that particular seizure disorder with minimal adverse effects. If they're seizure free, great. If they have seizures or they have significant adverse drug reactions, which we're going to talk about next, add on a second AED, titrate that to the therapeutic level, and then down titrate the first AED and get that one off. If they have no seizures after that, great. Well, then I found the best AED that reduces seizures and has very little adverse drug reactions. But if the patient continues to have seizures or they have adverse drug reactions to the second AED, then I need to consider two options. One is a combo therapy. In other words, I may need two AEDs. I may need something like levetiracetam and oxcarbazepine or carbamazepine to be able to meet that particular demand to stop the seizures. Or I need to pick a third AED and then decrease the actual second AED. So down titrate that second AED, maximize the efficacy of the third AED. So again, that's the big concept that I need you guys to understand. To come in, epilepsy, start them on a first one. They stop having seizures, great. They have seizures or they have adverse drug reactions, pick a different one and then get rid of the first one. They have no seizures, great, you found the perfect drug. They continue to have seizures or adverse drug reactions, get rid of the second one and pick a third one, pick a different one. So this would be the third AED in this particular situation, and then down titrate the second. Or you can pick two AEDs. Oftentimes, most patients, 2/3 out of most epileptic patients can respond to monotherapy. But if they require combination, that's when you have to kind of think about that with adverse drug reactions. If the patient continues from this to have no seizures, great. We found the best particular scenario for this patient, whether it be an alternative AED, that third AED, or a combo. If they continue to have seizures or they have an adverse drug reaction, then we're out of the possibility really of being able to maintain these seizures properly with AEDs. Oftentimes we need to go to something like a VNS, which is like a vagal nerve stimulator. Okay, that's outside of the window of this discussion. So that's the whole concept that I need you guys to understand. A patient comes in, they have epilepsy, you try an AED, first line for that particular situation. Doesn't work, they have adverse drug reactions, pick another one. Pick one that's gonna be a better option. So that's the second AED. They continue to have seizures or adverse drug reactions, get rid of the second one, try a third one that has an alternative type of therapy. And if that's maybe not best, then do combo therapy. Maybe you need two AEDs to suppress the seizures. And if they're still having seizures, then oftentimes you need to go to consider other alternative options. All right, beautiful. That's then gonna lead us into the next step here. How do we treat all the specific types of seizures? So focal seizures. When a patient has a focal seizure, really the big thing is that these patients have specific antiepileptics that have been researched to be most effective. And what are those antiepileptics? Oftentimes, this is one that I really want you guys to remember because it's likely to come up on your exam, is carbamazepine. I am a huge fan of this one, its cousin, the carbamazepine. I really like this drug. I found it to be very effective in my personal practice with shutting down focal seizures. Other drugs that have also been pretty good is levetiracetam. So levetiracetam is another one that's very good here. And then another one that's also been shown to be good a little bit is the lamotrigine. There's other drugs that can be considered as second line options. Things like phenytoin, fosphenytoin, valproate, topiramate. You can consider those particular drugs. Those are going to be the alternative or second line agents. The big ones that I really want you to take into consideration is the carbamazepine and the oxcarbazepine. These are big ones. One other one that I want to put down here just in a different type of color here, or just to kind of highlight here, is phenobarbital. So phenobarbital can be utilized to shut down these focal seizures, but it's a very specific population. I want you to remember phenobarbital. I know that sounds dumb, but phenobarbital, because this is best in neonates. So this is best in neonates, and this is actually really important. I don't want you guys to forget this, okay? So we can use phenobarbital in neonates who are having focal seizures. These are the big ones that I want you to remember. What about the generalized absence seizures, right? So absence seizures, everything goes blank, right? You come back later and you're like, man, what the heck happened? In those particular situations, there's there's a couple, but ethosuximide is going to be the preferred agent. If that's not an option, valproate is another one, and lamotrigine is another option. But again, I think it's really, really high yield to remember that ethosuximide is that preferred type of treatment, especially in the younger children, adolescent type of children who have generalized absence seizures. Okay, we move into the next situation here, which is, all right, we have focal seizures, we have generalized absence seizures. What about if we come down here, generalized myoclonic seizures, and then generalized tonic-clonic seizures? Let's talk about those. So the next one here is your generalized myoclonic seizures. So in this one, again, that kind of like rhythmic type of consistent movement, repetitive movement. In this particular situation, one thing that I found is that valproate, and evidence has found, is that valproate is very, very effective. Another one would be levetiracetam. This is very, very good as well at being able to shut down those seizures. Another one is, there's been some degree of efficacy with like lamotrigine as well. So lamotrigine is another one. And then benzodiazepines. These have also been shown to be very, very effective. But I'd say the most important ones is going to be valproate and levetiracetam. These have been shown to be very effective being able to treat myoclonus or myoclonic seizures. All right, now we come to the generalized tonic-clonic seizures. In generalized tonic-clonic seizures, that grand mal seizure, the really scary one, how do you treat this one? Oftentimes, valproate is a very good option. Valproate's very good. Another one would be levetiracetam is a very good one as well. Levetiracetam. Lamotrigine has been shown to be somewhat beneficial as well. Topiramate has been shown to be somewhat beneficial. Now, there is varying evidence on this, right? But some will even say that phenytoin, fosphenytoin is also pretty good in this particular situation. So phenytoin and then its cousin fosphenytoin have also been shown to some degree to have an efficacy as well. And then another one, which I don't want to forget here, is phenobarbital, right? Or phenobarbital. So phenobarbital, remember, in babies or neonates, this tends to be very effective at being able to shut down those generalized tonic-clonic seizures in neonates, which is really sad. But please don't forget valproate, levetiracetam, phenytoin, fosphenytoin, and phenobarbital, especially in these neonates. All right. So we've covered at this point, we've covered the specifically focal seizures, we've covered the absence, we've covered the tonic-clonic and the myoclonic seizures. Let's now talk about the next thing, which is what if a patient has, whether it be a focal seizure that continues and they lose consciousness, or a generalized seizure and they continue to seize for more than 5 minutes, or they seize and then they have, again, a little break, but then they seize again without a complete return to their functional baseline, then we have status epilepticus. How do we treat those? All right, my friends, so now we have a status epilepticus patient. In this particular scenario, we often do these in a very specific order. So we'll start off in this patient with benzodiazepines, right? So we always start off with benzodiazepines. And again, this goes back to this being the first type of step. So you start off with these when a patient comes in, you give them lorazepam, diazepam, midazolam, one of those two. After that, then you move on to the next step, which is adding on one of the other drugs that's going to prevent recurrent seizures. So it's as a prophylaxis. So this is where you can use drugs such as fosphenytoin is way more preferred in status as compared to phenytoin. Valproate is another potential option here. Levetiracetam is another potential option here. And then I've also come to be fond of lacosamide as well. But these are basically prophylactic at being able to prevent seizures when a patient is in status epilepticus. Then from there, if a patient still has seizures, they're still in status despite benzos and one of these agents, then oftentimes we do something like propofol or ketamine. And then if they still are kind of having seizures, we move to the last line, which is usually going to be the last step here, which is going to be barbiturates. So barbiturates would be the last step here. And this again would consist of which particular drugs? This would consist of your phenobarbital or pentobarbital. And generally when a patient requires barbiturates to the point of a pentobarbital state, they're usually at the point of almost needing to go into a coma. But this is how we would treat status epilepticus. Now, moving to the next state, which is this epileptic spasm. So in epileptic spasms, again, there's the benign Rolandic, the West syndrome, and Lennox-Gastaut syndrome. There's one particular drug that I want you guys to remember here, and this is lamotrigine. So lamotrigine, that's all I really want you guys to remember for this particular one here. But again, to highlight here, benzodiazepines, very, very important. And then this is very, very important for remembering in status epilepticus. Lamotrigine is the only agent that I really want you to remember here. And thankfully, there's only one specific agent that's high yield for West syndrome, and this is called vigabatrin. This is called vigabatrin. All right, let's talk about the last one, which is the Lennox-Gastaut syndrome. For Lennox-Gastaut syndrome, it's a really, really sad case. I've seen 2 of these in practice, and they're just terrible. For these ones, they often are refractory. Okay, so you can give them multiple antiepileptics. Oftentimes, they're still going to be continuing to have seizures. So some of these options that we can consider in this particular situation, valproate tends to be very good. Another one that you can consider here is topiramate. So topiramate's also a pretty decent option. Lamotrigine is another potential option here. Another one that I would also consider here, which we did not mention, but just for consistency's sake, cannabidiol. This has actually been shown to be very, very effective in patients who have Lennox-Gastaut syndrome. And then from there, we go into another drug, which is usually if they're super, super refractory, we can consider something like felbamate. But oftentimes, these patients require VNSs, as well as generalized tonic-clonic seizures that are uncontrollable, Lennox-Gastaut syndrome that's uncontrollable, and then also focal seizures that are uncontrollable sometimes will require VNSs. All right, my friends, so now we're on to the last part, which is adverse effects of these AEDs. So we kind of talked about how when a patient comes in, right, they're having focal seizures or generalized seizures. We know that the basic concept, the basic pathophysiology is there's increased glutamate and decreased GABA activity, right? That's the basic pathophys. And then we also have all these causes that we talked about. But whenever we have a patient who has these, we have to think about, okay, what kind of drugs could I give that would actually help to either turn down glutamate activity or increase GABA activity, right? And we went through all those, whether it be a sodium channel blocker, calcium channel blocker, SV2A receptor blocker, AMPA, NMDA receptor blocker to shut down glutamate, or a GABA-A agonist, a GABA reuptake inhibitor, or a GABA transaminase inhibitor. We talked about all those. Then we said, okay, if a patient has a focal seizure, we're gonna give them this drug. If they have generalized tonic-clonic, this one, etc. The choice of picking one of those drugs obviously comes from which has been shown to be most effective in this disorder. And believe me, I know it's going to be tough to memorize that entire list. Go through it, write it down with me, take a little break, go back, write them down again, just keep doing them to see if you guys can help yourselves through repetition go back through these. There's no beautiful, easy way, unfortunately, to remember those, except for just, unfortunately, a little bit of brunt memorization. But to help you for when the questions come up on the exam, this is where it's really helpful. So you're stuck between, okay, a patient is having focal seizures. Which one do I give them? Do I give them carbamazepine, oxcarbazepine? Do I give them levetiracetam? Do I give them lamotrigine? Really, it's thinking about the adverse effects that are actually concerning. So let's go through these. Which one of these drugs would cause significant cardiac and respiratory depression? In other words, they could cause things like bradycardia. They can cause low blood pressure. They can cause a decrease in your respiratory rate and a decrease in your depth. Which are drugs that have the ability to do this? And the ones that I really want you guys to remember is going to be your benzodiazepines. So your benzos, your barbiturates are really, really powerful. And then the other one here is going to be something like, what else? Propofol. Propofol is going to be another one. To some degree, things like phenytoin, fosphenytoin, they can cause that as well, but it's more likely the sedation that they cause. So they cause a degree of central nervous system depression, which can cause a small degree of bradycardia, hypotension, and decreased respiratory rate and depth, but not directly. These are the most profound ones that I want you to remember. The next thing is Stevens-Johnson syndrome. Everything is nasty, right? So basically, the patient has this multiple types of rashes, positive types of Nikolsky sign, all those different findings. And usually the most common ones is Ethan, Carl, and Larry. And you're like, what the stink is he talking about? So this is ethosuximide. Ethosuximide for Ethan. Carl for carbamazepine. Carbamazepine. And then Larry for lamotrigine. These tend to be the most common offenders of Stevens-Johnson syndrome. There's some that say like phenytoin, fosphenytoin as well, but these tend to be the ones that are most associated with it and the most likely ones to come up on the exam, okay? The next thing here is when a patient has hepatotoxicity. So in other words, if a patient has some type of underlying liver disease, it may be a good idea to avoid giving these particular agents and pick another one. What are those? So some that are actually going to be particular here that can cause a lot of liver damage and may require monitoring, because whenever there's liver damage, there's some degree of increase in things like your LFTs, your AST, ALT, alk phos, etc. These particular drugs have been shown to be able to cause this. So things like valproate is a really big one. Carbamazepine can also cause this. Carbamazepine. Another one is going to be felbamate. And this is that really, really powerful refractory one that we can see in Lennox-Gastaut syndrome. So these are the particular ones that I want you guys to remember. To some degree, phenytoin and fosphenytoin, but nowhere near as powerful as these particular ones. All right, we come to the next thing, which is these drugs can have drug-to-drug interactions. In other words, you give these particular drugs, they have the ability to act on the cytochrome P450 system, inhibit it or induce it. So you know that inducers do what? They stimulate the cytochrome P450 system. So they want to stimulate the cytochrome P450 system so that you break down the drug more quickly and you decrease the efficacy of the drug. So you decrease the drug levels of something else. So if you're taking this antiepileptic plus another drug, you're going to decrease the efficacy of that other drug. Whereas cytochrome P450 inhibitors, they're going to inhibit the cytochrome P450 system so they don't break down the drug, and this would potentially increase the concentration of the drug, making it super therapeutic. These are going to be things like barbiturates, right? So barbiturates. So this is going to be your phenobarbital, your pentobarbital. These are very, very powerful cytochrome P450 inducers, so they will decrease the efficacy of other drugs. Other ones that you want to remember is going to be something like phenytoin, fosphenytoin. But more specifically, we found that phenytoin is a little bit more powerful. So phenytoin is a really, really big one here. And the last one is carbamazepine. So carbamazepine. Carbamazepine. Now, when we have all of these particular drugs here, again, it comes down to which one do I pick? Well, which is the one that's, again, going to have the least adverse effects? So these have a pretty decent adverse effect profile if it's going to cause a lot of drug-drug interaction. The one that really causes cytochrome P450 inhibition, which can increase the efficacy of other drugs, is going to be valproate. So that's what I really want you to remember. So again, a quick recap here. Cardiac respiratory depression, benzos, barbiturates, and propofol. Stevens-Johnson syndrome, Ethan, Carl, Larry. Ethosuximide, it's going to be then the next one, lamotrigine, and then last one is going to be carbamazepine. Hepatotoxicity, valproate, carbamazepine, and felbamate. And then CYP450 interactions. In other words, it can alter the efficacy of other drugs. The ones that'll decrease the efficacy of another drug would be carbamazepine, phenytoin, and barbiturates. And the ones that can actually do what? Increase the efficacy of another drug, it is going to be valproate. All right, let's now come down and talk about which drugs are actually dangerous in pregnancy or childbearing women, and then some specific ADRs that may come up in your exam. All right, so teratogenic, meaning that it's actually very dangerous to women who are pregnant or of childbearing age and looking to have a child. You have to be able to remember these. So what are some of these? These particular drugs that I really, really want you to remember here is going to be valproate. This one is likely to be the most teratogenic, and the reason why is it can cause a lot of inhibition of folate production. which can lead to something called neural tube defects. And this is really, really sad. You don't want to really see this in patients. So be very cognizant in trying to avoid these particular agents in a patient who is pregnant. Another one would be your phenytoin. So your phenytoin or fosphenytoin. These ones have been shown to cause something called fetal hydantoin syndrome. Hydantoin syndrome. So fetal hydantoin syndrome is a really, really big one. So don't forget that one. And the last one is carbamazepine. So carbamazepine is going to cause things like cleft lip and a cleft palate. And these are really, really sad things. So you really want to be able to pick this up and make sure that you don't miss this whenever a patient is pregnant. I wouldn't want to put a patient who has generalized tonic-clonic seizures on valproate who's potentially pregnant or looking to be of childbearing age and looking to get pregnant. They have this high risk of neural tube defects. To generalized tonic-clonic seizures or status epilepticus of a patient, I wouldn't want to give them phenytoin, fosphenytoin. Focal seizures, I wouldn't want to give carbamazepine. All right? Couple other things to remember that may come up on the exam because they love to ask these questions because they're always usually the likely thing to be questioned on is other specific big high yield buzz term ADRs. Valproate, specifically watch out for pancreatitis. So inflammation of the pancreas is pretty common. Also, it may drop the platelets, so thrombocytopenia, but pancreatitis is the big one. Carbamazepine, it may produce SIADH, which may cause the patient to have a hyponatremia. So watch out for that with carbamazepine and oxcarbazepine. Phenytoin, fosphenytoin, really weird one, but it's important to remember it can cause a very significant thickening and increased production of the gingiva, which is called gingival hyperplasia. That's another big one, and if you stop that use, it will actually regress back to the normal position. Vigabatrin, vigabatrin vision loss is a big one. And then last but not least, my friends, is topiramate. This one has been shown to cause things like metabolic acidosis, as well as kidney stones. And to some degree, relatively rare, but glaucoma as well. But I really want you to remember metabolic acidosis, and then again, kidney stones, because they're likely going to be the most common causes that you can see with that drug. All right, my friends, that covers the whiteboard section, but let's quickly do some questions to see if we can test your knowledge and understand everything we went over. All right, my friends, so let's do some questions here. So first one, we have a 9-year-old boy sent for a neuroevaluation because of episodes of apparent inattention, right? So over the past year, he's been having these kind of episodes where he develops a kind of a blank look in his face, his eyes blink for about 15 seconds, and then he resumes his previous activity like nothing ever happened. Which best describes this type of seizure? Well, remember, there's focal seizures, right? There's generalized seizures. Within the generalized category, there is tonic-clonic, tonic-clonic, there's atonic, myoclonic, and then absence. Remember I told you that this is tonic-clonic, this is tonic, this is clonic. Atonic is you go limp, myoclonic is rhythmic kind of jerking, quick movement, and then absence is you stare out. So this would fit an absence seizure, right? So that's classic in young individuals who kind of have these blank stares in class. Pretty classic. All right, child is experiencing absence seizures that interrupt his ability to pay attention during school. Which is the most appropriate therapy for this patient? The most common answer is ethosuximide. Remember, absence seizures, you can use things like valproate, you can use lamotrigine, or you can use ethosuximide. Generally in children, ethosuximide is preferred. Okay, but other options include valproate and lamotrigine. So which drug is most useful for the treatment of absence seizures? Again, it could be lamotrigine, valproate, or ethosuximide. Ethosuximide is preferred for children, but you could also use something like in this category. Is there valproate? No. Is there lamotrigine? Yes. So it's got to be lamotrigine. All right. 25-year-old woman with generalized seizures is well controlled on valproate. Okay, so she's taking this for generalized seizures, likely tonic-clonic. She indicates that she is interested in becoming pregnant in the next year with respect to her anti-seizure medication, which of the following should be considered. Remember, valproate, carbamazepine, and phenytoin, fosphenytoin have teratogenic effects, so I need to avoid those drugs at all costs. So I would just discontinue her off of that, and if I could switch to something that has less type of toxic effects. And so leave her on her current therapy. No. Switch to lamotrigine. There's no teratogenic effect of lamotrigine. Add a second anti-seizure. No, because then she's still on valproate, or decrease her valproate dose. No, just get rid of it. So best answer would be switch to another one that's not teratogenic, such as lamotrigine. Okay, so that'd be the best option here. All right, patient with focal seizures has been treated for 6 months with carbamazepine. It's great for focal seizures. That, as well as oxcarbazepine, are going to be good ones in this particular situation. Levetiracetam, lamotrigine, topiramate to some degree, phenytoin, fosphenytoin, not so great, but valproate's also kind of okay in this particular scenario. But generally, lamotrigine, topiramate, levetiracetam, oxcarbazepine, and carbamazepine are the preferable ones. So, with that being said, having some breakthrough seizures on a more frequent basis, you're considering adding a second drug to the anti-seizure regimen. Which of the following drugs is least likely to have a pharmacokinetic interaction with carbamazepine? So this is basically saying which one of these drugs has less kind of cytochrome P450 interactions in comparison to others. And the one that I think is really, really important to remember that really has almost no drug interactions because it's primarily renally excreted is levetiracetam. So levetiracetam is going to be one of the best drugs with less drug-drug interactions as well as very little adverse effects. 75-year-old woman had a stroke approximately 1 month ago. She was continuing to have small focal seizures. So again, focal seizures, oxcarbazepine, carbamazepine, levetiracetam is a potential option here, as well as lamotrigine, topiramate. Those are all options. And then phenobarbital and neonates. Remember, phenobarbital. But in this situation, they can have small focal seizures, which she fails to respond appropriately while talking, which is the most appropriate treatment for this individual. So for a focal seizure, you could consider oxcarbazepine, phenytoin, levetiracetam, or phenobarbital. Between these, phenobarbital is not a good option. Okay, that's usually going to be for more patients like, remember, neonates is the preferable agents, or status epilepticus refractory. Phenytoin's not super great for patients who have, again, focal seizures. So it leaves oxcarbazepine and levetiracetam. These are both great agents. So I think when it comes down to it, I would consider levetiracetam to be the preferable agent just because of age. All right, so levetiracetam, and it's going to have way little adverse effects. So I'd go with that one being the option, levetiracetam. But again, oxcarbazepine is not a bad option. You could also consider that one. All right, my friends, so that covers these questions here regarding the anti-seizure or drugs for epilepsy medications. I hope it made sense. I hope that you guys enjoyed it. As always, until next time.